So fine, it's a panel on complication of hysteroscopy.
Welcome, Sandeep.
Welcome, Sandeep bhai.
Hi, Subhash.
We are two
Welcome,
good friend
Sandeep.
of all of you, me, Farendra, and Subhash bhai. And our panelists, we have already introduced Sandeep Datta Roy, Amit Tanjay, and Anita Mahe, Divya Madam, Jayesh bhai, Shyam sir, and Amol. So welcome all. So we'll start the panel. We all know that hysteroscopy is revolutionary science in the organic diseases, and it's gradually increasing its spectrum. Very important line, and it's very cost effective and a time effective procedure to treat most of the symptomatic gynecological pathology. But it has its own spectrum of complications, which are early and late. So we'll start our panel. So we really wanted to know, Sandeep bhai, that is there anything, any untold story which you really want to discuss with us? You all have to, all of you must have faced some complication, and we wanted you to speak it out so that our audience will be straight away benefited, and we'll have a
I would just like to intervene here for 30 seconds.
Yes.
Like,
Yes.
I need everybody in this panel to, please follow like how you tell in the code. जो भी कहूँगा सच के सिवा कुछ नहीं कहूँगा.
Yes,
Because
yes.
here we are here to
Yes.
share our problems. We are not here to say how good we are or how bad we are. We are
Yes.
here to share our complications, and it really needs a lot of guts, to accept our complications. Sandeep bhai, no offense to you. First is yours. So we will like to hear from you.
Yeah, Subhash, I'll not talk about the perforation, fluid overload, and all these things. Like we all know all these complications. In last 12 years of my practice, I had 4 mortalities, 2 in laparoscopy and 2 in hysteroscopy. So in hysteroscopy, both these complications were air embolism. I should say, because one patient I lost on the table and one patient died in the ICU next day. So what happened when we reviewed the cases? One patient, we had found that she had some cardiac diseases which was not told to us before. So on the table, she, like when we just started doing the hysteroscopy, like she collapsed on the table itself, and then like immediately we had a cardiologist call. Even so the cardiologist came.
There's some network instability.
Sandeep,
Yeah.
we could hear you.
The moment like the patient collapsed, the ETO2, everything fell down, and then SPO, everything was like within second was like almost 0. So this
Sandeep bhai, you can just stop your videos and continue with your voice. By this way we can get your wonderful.
Yeah. So what happened is like patient immediately collapsed, and like when you reviewed the video, what we could see in the first case, 1 or 2 bubbles that actually entered into the there was a embolism. So this patient actually she died on the table. Then another case, the second case that I was doing, it was quite a long time back in the periphery.
Sandeep bhai, I'm just stopping you here at this juncture because let's make it a discussion. See, you said that during your videos you have seen few bubbles which are going into the where it was going. It was going into the in the Philippine tube, or it's going somewhere else.
Actually, this patient, not in the fallopian tube, it was going near the fundus. What I could see in the fundus, some area of the endometrium was eroded. I don't know whether the hysteroscope touched there or something, which I don't know, but it is in the fundal area, the endometrium was eroded, and I could see few bubbles going into that. So probably there was a air in the tube itself which was not cleared, and then probably it went through the hysteroscope, and then through the open vessels it entered into the this thing. This was the
create
first
air embolism. You need a good amount of air to move into the the vascular tree.
Exactly.
Yeah, Anita, may I just intervene here? Anita, what is your take on this particular case? Now he has said that most of us, let's be very frank, most of us when we have some amount of air bubbles. So next time, should we be very careful about this or not?
Exactly.
First Anita, and then I'll follow by Amit. Yeah, Anita, please.
Sir, I think the first and foremost is definitely the air purging that we should use. 90% of the time, it is the air that is coming through the tubing that have directly gone into the uterus through that thing. And most of the time, we have seen that what I have seen in one patient of mine when I was a PG student, the moment they introduced the hysteroscope into the cervix, the patient collapsed at that time only. So the most probably the cause may be the room air going to the cervix, so that may be the one of the causes. So whenever they say that whenever you dilate the ideally so we are going with the vaginoscopy, but when you are dilating with the cervical dilator, so you put the
Anita,
dilator, keep that in situ
Anita?
only and do not take it out.
Yeah, Anita,
And immediately
सच
introduce.
सच कहना, सच कहना, वेजिनोस्कोपी करती हो या डायलेटर पकड़ के करती हो?
नहीं sir, I have learned with vaginoscopy always. In
Good.
Very
fact,
good.
people
Good. Very
tell
good.
me
Very
to
good.
hold
Very
it,
good.
I refuse them to do it.
Yeah.
So
Amit
I
bhai,
always do
Amit bhai,
vaginoscopy.
your take. No,
Yes, yes, sir.
because you know what? Bhaskar sir
Actually,
has given us, 1 hour. He's been very magnanimous with 1 hour, but I think we are already short of time. So I think we'll just go first.
yes,
Amit bhai,
yes.
your take on air bubble and embolism.
Actually, air bubble. What we follow in my hospital and in my practice, we used to do the first check all tubings, and first remove before introducing. Am I clear? My voice is clear?
Yes, Amit.
Because
Yes.
because something is playing. I'm just sitting in the hotel for the dinner. Sorry for this. And we regularly keep a one person at where we put the saline bottles, and when we change, we used to attach two bottles. We used to prefer a 3 liter. If not available, then we used to prefer a 1 liter and attach two bottles at a time, normal saline bottles. And we have to clear the whole tubing before entering into the vagina also. Before entering into the vagina, and one person keep eye on that bottles. And my strictly instructions are there. Whenever there is 100 ml of saline remaining, just close it. And
So Amit,
just stop it.
I'm just stopping you because we'll have to ask many questions. So
Surendra
the
sir.
important thing is that avoid dilator, because this dilator creates
Yes,
a
yes.
suction into the uterus, one thing, and which can
Yes.
suck the air inside. Second thing,
Yes.
what Sandeep has said, any pathology which is lying near the cornua or on the fundus are prone for air embolism and gas embolism. Please
Absolutely.
make it very
Yes.
clear, because they have a connection by which it can, anastomotic ovarian vessels, by which it can straight away move into the system. And these are the things which we have seen. So you should be very careful when you're dealing with the fundal and the cornual pathologies.
Normal pathology.
So if I can sum up
Yes,
this,
yes.
whatever has been said is first check all the tubings, let
Yes.
all the fluid come out. Do not allow any air bubble. If you see an air bubble, let the air bubble go off and then you insert inside. Secondly, as has been told by Farinder, do not over dilate it. Right? Third, check for all the tubings which you've already done. But whenever you are using 2 saline tubes or whenever using 3 liters of fluid, as Amit has said, be careful that the moment you have about 150 ml, shout it out in the theater. Okay, whatever happens, sir, मैं बंद कर रहा हूँ.
Yes, yes.
That is very, very important. Okay. Now,
And
anything
sir,
else?
I would
Yes,
Any-
yes,
like to
Shyam
I
add
bhai.
just
one
want
thing.
to
Yes,
add
Shyam bhai. Yes,
Yeah.
Shyam.
Yeah, whenever we go outside our hospital, the stirrups are not that the angle of the stirrups is more than should be 90 degree, or it's a 120 degree. We should make it first. Then the position, avoid the two flexion or avoid the Trendelenburg position. That is, we should do it
Yes.
first and then start the procedure. As sir said, all air bubbles should be removed and check the tubing, and we can the outflow we can open it. And initially we require a more pressure, that is more than 100. And what should be the pressure is mean arterial pressure, as low as mean arterial pressure or below that. So sudden rise of the pressure initially may cause an embolism. In this case, even less than 5 microns of the vessel is open, then within a minute, half liter of the fluid we can which will go in intravascular.
Yeah. So I think we'll go to the next one, Farinder bhai.
And one more thing here, I had to don't use that bags also.
Yeah,
exactly.
the histomat should be used.
Histeromat should be
Yeah,
used.
histomat should be used.
Yeah.
As we use in laparoscopy as an
But
insufflator, then why to
70
use that pressure bag?
75% of hysteroscopies even today are done with
Yes, yes.
not
Those
with
who are
histomat.
But we
for a diagnostic procedure, I think we
But
can
one should not
use the
use it.
pressure bag. But for an operative case, we should use a histomat because the procedure is prolonged, and then we have to change the too many salines. At that time, we should calculate, and Euro bag that available Euro drape is available. Now we should calculate the how much is the outflow and what has gone in intravascular. So that
and avoid multiple insertions also.
yeah.
But
Piston
Subhash
neck
bhai,
action
we
of the
one should have to be shift on the, because we are not using fuspus inside the abdomen, na? While doing the laparoscopy, one should have to invest in the that histomat.
Now there is some issue with there is some issue with Dr. Farender. He has just been logged out. He'll just join us in about a minute. In the meantime, till the PowerPoint was, my next question would have been, whenever have you abandoned any case? Have you abandoned any case till date? Now let me ask Amol bhai. Amol bhai, have you just abandoned any case till date in hysteroscopy? In hysteroscopy.
Yeah, last week what happened is there was a myoma inside, and I inserted my resectoscope. First, I did a diagnostic, then inserted the resectoscope, and suddenly the cautery failed. So, but in between, there was a panicky situation. ये wire लगाओ, वो wire लगाओ, there's permutation, combinations. It didn't work. In between, the myoma at the base of the anterior wall got separated, and myoma was completely free, and it is moving inside the cavity, and it was a 2 to 3 centimeter. 2 to 3 centimeter, and we were
if I may stop you, sir,
myoma.
Yeah, if I may stop you here. Once he used the word that the cautery was not working. But mind you, when you say that the cautery is not working, your idea should not be to increase the voltage. Please understand, your idea should not be. You should always check your current, check your circuit, than increasing the voltage. Please understand this.
Yes.
That is one basic thing mistake. Nahi chal raha hai, aur badhao. That is the wrong thing. Right? Now, Farender bhai is back. Farender bhai, I've just started with the difficult anticipated surgery. Over to you. Yeah, I think you were telling about the
myoma.
What happened?
We were fighting for 1.5 hours to take out that myoma, but we couldn't do it. So ultimately, I have to stop that procedure, tell the relatives, and then the patient posted for the hysterectomy in the next week. And
what was the size of the fibroid? So what was the size of the fibroid?
It was a 2 to 3 centimeter.
Okay. Sir, because I will just ask, suppose you're doing a submucous fibroid or you're doing a polyp. Now, out of the two, in case, worst case scenario, you leave it behind. Which is the one that you would love to leave behind? You will leave the fibroid or the polyp?
Obviously, fibroid.
Yeah, I think it's very good because the fibroid will not have the epithelial lining, whereas the polypoidal lesion will have an epithelial lining. There can be infective foci. Hence, even if you get stuck up, I think even if you leave the fibroid, it may come out. It may come out. The uterus will try to expel it out. Okay, right. Farender, are you there?
I also had.
Yeah, please take over. Please take over.
I also had the same patient.
I was a stopgap because you are not there. Please.
Okay. So I had a patient who has a 2 to 3 centimeter fibroid grade 1. She was referred in view of myomectomy only, but she was already had surgery. So there was a dense adhesions inside. So I went inside with a hystoscope and had perforated. So definitely there was no distension, but I have to do it. So I went in for laparoscopy and then I removed laparoscopy.
No, we'll come down to what आपने जो कहा है ना, like Dr. Puntambekkar's anatomy. It comes 10 seconds prior to what we think. So you have come 10 seconds because that is the next slide of Farender bhai. Farender bhai, please take over.
Yes. So fine. Already Dr. Anita has said that she has done a laparoscopy. Am I audible now?
One point.
Slide, please. Can you please change the slide, Farender bhai?
Yes.
Yeah.
Again, next important thing is, have you abandoned any procedure any day?
We just discussed that, Farender bhai. By the time you are not there, we just discussed that. We'll go to the next slide.
Wonderful.
Next slide. Yes,
So
please take over.
It's a false passage.
Looks false passage. Wonderful. So what is your diagnosis is clear. How will you prevent? I mean, who wants to take this question?
I think we should abandon the procedure.
Divya is okay.
Yes.
Amol bhai followed by Divya because Divya is very silent.
Divya madam.
Yeah. So the vaginoscopy approach actually helps a lot, and going slowly let the fluid do the little bit of distension and increase the visibility. By that mannerism itself, we can easily distinguish between which is going to be your false passage and which is your true endometrial lining. And sometimes we see those two, like the septum, we just see two osses or two areas. We don't know where to go into, which is the false passage and which is the right one. Just going near that and increasing a little bit of pressure, I think, will open up the real passage a little better, and going down a little bit. And usually we find making these false passages in the posterior myometrium rather than the anterior myometrium, because you are really careful with the angulation. So waiting a little bit, it will open up the passage, and then going in would be better. So that's one way. If you've already made a false passage, to not go into the false passage again and do it.
Very good. And what are the risk factor? What are the risk factor, Dr. Amit? Amit, are you there?
Yes, I am here.
What are the risk factor in which you can expect that you may land up into false passages?
Risk factors are the angulation of the uterus, and that may lead to the false passage and in Asherman cases.
Okay.
And here, how can we prevent? We should have to avoid the use of dilators. We should check the before surgery beforehand the angulation, and without using the dilator, use 2.9 mm hysteroscope. And
what Farendra Bhai is trying to suggest is, of course, you will do it. You will do a bimanual examination for sure. Definitely, a PV is a must. Nowadays, in the advent of hysteroscopy, we have forgotten our pervaginal examination.
No.
What he is suggesting is there a role of ultrasound?
Yes.
In difficult anticipation.
Yes.
That's what Farendra Bhai is asking.
Definitely.
Yes, definitely.
I think the use of the tablet misoprostol 400 microgram prior to the surgery and the non-touch technique, no speculum, no valcellum, and we are going by almost now everybody is going by a vaginoscopy, and we thought that the cervical canal is rounded as a perfect canal, and it's a elusive. Sometimes it rotates to the right, sometimes it's left, and often posterior ridge is there. And if you force the hysteroscope at that moment, that posterior ridge will go into the myometrium, and the crisscross fibers that assumes like an Asherman's, and we come out and sometimes diagnose an Asherman syndrome. So I think by doing a vaginoscopy, non-touch technique, we can negotiate into the cervical canal, internal os, we can negotiate, and we can have a beautiful view intrauterine.
And also one point here to add that you have to wait, just go inside the external os and just behind from the internal os, because cavity fills from inside to outside, and your water pressure dilates the cervix.
Yes.
And just follow that.
Correct.
Whenever you feel like there is a resistance, you just come out few millimeters behind and go ahead. Then when you go 2 steps ahead, come 1 step behind. So that is the technique of simultaneous dilatation. And obviously misoprostol is going to help it.
So in a nutshell, what Amol Bhai said, Shantapanar karaycha hai. So be very
So all these things, pre-operative prediction by doing a clinical examination, history of a patient, high-risk patients are Asherman disease, previous failed entry,
Cervical fibroids also.
Cervical fibroids. I mean, the video which I'm showing is almost at the level of internal os. There was a big adenomyoma which was deviating the cavity. You can easily land up into false passages. So with your clinical experience, with your experience in hysteroscopy, sometimes you can find out the natural passage or the exact entry. But in cases of Asherman, if you have landed up into a false passages, as sir has said, that you can abandon the procedure, and then later on you can plan this patient, or especially on the day of menses or last day of menses, where the blood and can direct you towards the canal, and misoprostol has certain role, and you can reach into the cavity and finish complete this procedure. So anything you want to add, Subhash bhai?
Summarizing what Farendra bhai has said, that in such cases always, you do your per vaginal examination, you do a PV, very good bimanual examination. Secondly, use of misoprostol will be helpful in anticipated failure cases or difficult cases. Again, as Farendra bhai has said, on the last day of menses, if you do it, it will be a very good one. Again, use of an hysteroscopic Caesar also. We have seen a couple of videos from
Yes.
Nitin Shah and also Farendra bhai, where you use a Caesar slowly, either with a Caesar or with a grasper. Just open it up. You just open it up, and that's what you see. That's one thing which is rightly said. And of course, ultrasound, as we all know, in a short deviation from the topic, we have a very good ultrasound workshop also coming up in Mumbai at Mahatma Gandhi Jaipur, also coming up in the month of September. I think we should
next month only, in the month of February,
next month.
17, 18. Yes.
Now, again, taking over this case. Now, starting from here, Divya, can you just guide us, followed by Sandeep? How do we do and how are we going about this? Farendra bhai, can we start from the beginning? Can we start?
Yes. This was the in the summary of the same previous false passage, that these are the risk cases: cervical atrophy, cervical surgery, divided canal.
To add on to what Amol bhai said, whenever you do not see, come back. In hysteroscopy, there is no place, Dikh nahi raha hai, aage badho nahi. Aage badho doesn't come in this. There is no heroism here. Stay back, watch, allow the water to distend, and then you go.
Exactly.
As you would know, a very small movement in hysteroscopy is as a big movement on the screen. Hence, your hand should be very, very careful, very, very precise movements. Kehna aasan hai, karna mushkil hai, but I do understand that. But still, that's what we normally follow. Right? Now, Divya, the next case to you, Farendra bhai will take you over. Yeah.
Yes. So, Dr. Divya, it's a very clear-cut case. A 32-year-old patient undergone hysteroscopic myomectomy under general anesthesia. Patient had a hemoglobin of 6 grams, for which she received 3 units of blood. Now the HB is 9.4. During the surgery, her temperature has gone down, SpO2 has fallen, hypertension, tachypnea, tachycardia. We all know that what is the diagnosis. So, Dr. Divya?
I had a similar patient, sir. When he asked, have you ever abandoned? I had abandoned once down. Yeah. It was, actually the hysteroscopy is the one case where we are happy to even abandon at certain times.
Yes.
I had a similar patient. We had treated that lady, our very own in-house nurse. We had given her 4 transfusions. Then we had taken her up like second day after the transfusion. Immediately, as soon as we went in and we started dissecting the first myoma, the first cut itself, she had so much of frothy sputum coming out, and she went in for pulmonary edema, and the volume overload was instant. I don't know why, but because then we understood, talking to the cardiologists and everyone, we understood that these anemia treated patients, the hemodynamically, they are totally unstable. The volume overload is already there because of our transfusion, and the blood is so thin. And we keep pushing in a lot of more water through the hysteroscope is creating a lot of pulmonary edema. So that's when I realized that if you have transfused and taken up a patient, I usually give them some time before we go into the next patient.
If I may intervene and ask you, is there one particular thing during the surgery which you will use, which will help you in detecting early pulmonary edema, and that would be?
Falling ETC2.
No.
This parotid swelling is there.
Parotid swelling is later on.
Parotid swelling, it comes down slightly later. I think the first thing that you do is put in a simple pulse oximeter.
Okay,
the moment your SpO2 goes less than 92%, you have to start thinking in terms of your pink frothy sputum and everything. Parotid sign would come slightly late.
Yes.
The moment your SpO2 falls less than 92%, that means there is some.
In fact, you should not wait for 92. Suppose a patient is maintaining, if you are operating in GA, maintaining a saturation of 98 to 100%. If it goes below 96, and you suspect that this is a high-risk patient, had a blood transfusion received, you are doing a thick muscular septum, big myomas, stop there and there only. Reassess, allow the anesthetist to settle everything, and then again you can restart.
Yeah, if I may add one patient, especially in this type of cases, like where you give blood transfusion and take patients for surgery, always give Lasix before surgery, because whatever you do, some amount of fluid goes into the vasculature.
100%.
So that itself actually gives you some protection.
In fact, I would say don't post patient for major hysteroscopic surgery immediately after blood transfusion.
Exactly,
Yes, sir.
exactly. That's
Exactly.
Very
Right.
much.
The count which is
We could have
increasing.
given GNH
Point to
or
be noted.
analogs
Yes,
also.
by time, that is very important. You are giving blood just because the hemoglobin is 6 temporarily. You make them aminoric by giving GnRH, OC pills, or
exactly.
whatever you want to
Yes.
give. By a time of 1 month, stabilize the patient and then post them for surgery. As Dr. Sandeep has said,
Hope there
giving
was a
early
webinar
Lasix
like
and
this
prophylactic
teaching
Lasix
us.
doesn't make any difference. You can put a catheter, give a Lasix, and proceed for surgery. As most of us nowadays are operating with underwater saline bipolars, resectoscope. Most of us are not using glycine. Glycine has its own way of complications. All of us have stopped using glycine 10 years back.
Yes.
And that is why we are not discussing today. Nowadays, we are discussing fluid overload, and it can be easily tackled. So my next question is that, I wanted to show this small video. It's my boss, he taught me the, whether it's playing.
ABCD.
Yeah. See, that's a fluid balance. He's Dr.
Very
Nahata,
nice.
my boss,
Dr.
who taught
Nahata in
me
his glory.
most of my
I
hysteroscopies.
I think Jamal Kudu was based on Abrar.
Yes,
was
yes.
based
Jamal
on this.
learned from him only.
Exactly. Abrar learned from him only.
Yes. So my next question is, what is your own fluid guidelines?
Yeah, who would
Anybody?
like Shambai? Shambai
My-
would like to take this case?
Yeah,
Yeah, Anita, please. Anita.
So
whenever
my guideline is that 15 minutes, sir. If my surgery is going beyond 15 minutes, I alert
Yeah.
everybody,
Very
because
good.
I know this is my time. This time might be differ for somebody else also. And
Alert का मतलब आवाज करोगी या
नहीं, anesthetics को बता दूंगी सर, anesthetics को बता दूंगी कि you check on vitals, because if it is going more than 50 minutes, because 90% of the time, since I am a freelancer, I don't have histomat everywhere. So I work on this thing, and not every time I have the person, a very guided person, to have a fluid deficiency.
Farendra bhai?
So
Yes.
now you get why I told जो भी कहूंगा सच के सिवा कुछ नहीं कहूंगा।
बिल्कुल,
इससे पहले
बिल्कुल।
गीता पे हाथ रखा था।
हाँ तो रखा था सर, बताया ना कि मेरे पास नहीं रहता है सर, तो I have to so I keep my time, so that because I know that I'll be able to finish surgery, or what is the fluid overload will. So at that time I alert my anesthetics that
Yes.
this is going to be a challenging case or whatever it is. So keep on telling me. And second thing is, I carry this V-shaped bag with me. So whenever I go outside for performing surgery, that almost keeps me in check, that what is the fluid
Fluid
going
deficit.
outside.
Shambai, what will be your guidelines? What will be your
Yeah.
fluid guidelines? Anita has given hers.
We should have a count of the fluid, because the surgeon who is operating, who is doing a septum resection or some other surgery, he cannot measure and what is going on the floor, what should be the fluid in the floor. We cannot measure
लेकिन
it.
मेरे
So we have
थिएटर में तो
that
स्टाफ ही
bag.
नहीं है बॉस। श्याम भाई, मेरे थिएटर में स्टाफ कम है, कैसे करूंगा मैं ये सब?
Yeah, you should have, whenever you are changing your bottles,
Yeah,
then
this
you should
V-shaped drapes are very
aware all
useful.
the OT staff how much bottles you are changing. That is the first thing. And you should have a use the urology drape that could guide you.
V-drape.
Drape that will guide you how much is the outflow, and that will prevent the TURP like syndrome. That will prevent the syndrome. And if your normal saline using it, the significant volume is 1.5 liter deficit is there, 1 to 1.5 liter, then you should stop the procedure.
In a cardio normal patient.
Normal patient.
Yeah.
1.5 liters is the maximum limit. Okay.
Yes.
Now,
And
let me
Threshold, sir,
Well,
the threshold for us abandoning a procedure or stopping a procedure usually changes if we are in the home ground, if you have a good anesthetist, and if you know that if there is some problem, you know that there is a guide for you to take to help you out when there's a problem. We're a little brave. At the same way, when we have something like a grade 0 myoma, which is just dangling there, we know that there's not much of an absorption.
Divya,
Then also we take more time.
Divya, not everybody is lucky to have her husband as anesthetist.
No.
We should,
He doesn't operate with me.
At the cost of the patient, we should abandon the procedure if any warning signs are there, and we can finish the procedure in a later date.
Shamba, you talked about his warning signs. myself and Farinder, we do not know what are the warning signs. Can you please tell us what are the warning signs?
If the diastolic blood pressure, if is more than the 15 millimeter of previously recorded, that is one thing. You said already said the saturation, which is dropping with the general anesthesia patient is there, and the fluid deficit you are counting a normal patient at the more than 1000 ml, and if somebody is using a glycine, the significant threshold is around 500 ml. So very cautious while using a glycine. And now
Glycine,
everyone has
500 ml. I may not agree because sometimes even if you go up to about 1
Glycine,
liter also, it's
we
okay.
stopped using
But again,
since long time.
Dr. Farinder has shown us a very nice pink color thing. Can somebody elaborate on the pink color thing? Or Dr. Farinder, could you please you yourself tell us about the pink color wala? Yeah. Can somebody just elaborate on this?
This is a floor suction that keeps on telling you that on the floor what is there.
Exactly. I mean, all these pictures will help you in calculating the deficit. But as a surgeon, hysteroscopic surgeon, you know that how much fluid you are pushing into this particular case. So you should be very careful. I have seen, there are certain technique. We are not going into the details, but there are very high risk cases, especially a muscular septum and a myoma, which is more of a type 1 or 2, are prone to get more of the fluid into the intravascular system. I've seen very many surgeons operating right from the base and then removing the chip. I am very say like the vessels, the venous channels are more into the base. So targeting the base right from the beginning is not a good idea in cases of myoma. And you should be a decently fast enough surgeon to finish this thick muscular and myomatous surgeries. This is what I mean to say. In the beginning, you should not start with a big myomas and a big muscular septums. So please be careful. And fluid overload, we all of us have seen mortalities. So make your own protocol, work with your team, especially if you're a freelancer, you have to be very careful when you're dealing with such a complicated cases.
Yes.
Sandeep,
So
can you please?
whatever ways we have to control the flood, it doesn't work like the Mumbai or Chennai floods. Whatever you have to measure, it doesn't work. That's the truth.
Correct.
Mostly we get stuck once we know that it is not going to cause a problem. We just go on with the floods. Only when the water enters our house, we understand that yes, we are caught.
So that's
I think those life lessons, those 2-3 things, not to post these patients, totally say no. Saying no is one in this area alone is okay with us. Our ego has to come down a bit.
Sandeep, are you there? Sandeep bhai?
I still wanted to hear from Jayesh bhai. Jayesh bhai has joined.
Jayesh bhai शादी में है. अभी शायद मैं एक बार फिर फोन करता हूँ.
No problem.
Okay.
And Amol bhai is there?
Yeah,
Yes,
Amol bhai is there.
Amol bhai,
Yeah,
this question is for you. Just see this video.
In the meantime, Sandeep, can you join us? Sandeep? Yeah, Amit bhai, party शुरू हुई क्या रायपुर में?
No, I am here.
अच्छा, thank God. I hope Dr. Rishikesh is also there with you. Rishikesh Pandit, another great surgeon.
Dr. Rishikesh is also
Namaste
with me.
Rishikesh. Namaste Rishikesh.
The cavity is completely filled with adhesions.
Yeah. Subhash bhai clearly describe when you're seeing many white fibers, crisscross fibers. I've heard his lecture. Exactly, you're not getting any. And this was a case of Asher, man.
Yeah.
Rishikesh, if you don't mind, you can also join us, Rishikesh, because
Yes.
Jayesh bhai is also not aware. We would love you to have. Please do join us. Please accept our request.
Rishikesh.
Thank you, sir.
Dr. Rishikesh Pandit is a fantastic surgeon, very good radical surgeon from Aurangabad. Naitari. Nagar Madhe. We have a big infantry there in Nagar, na?
The surgeon is, going again, coming back, identifying the landmarks, cervical canal, rugosities, and then going back whether he or she is going in a correct plane. He or she, guys, it's me only. All are my videos. So, fine. Again, I'm coming back and identifying myself whether I'm going in a correct plane or not. Because to me, it looks like a false passage I'm entering, but still I have to finish the surgery. So, as I said, I'm going to perforated.
Radicals are there.
Yes, it's a false passage again.
No,
But
I am reminded of that, the ad from, laga, nahi laga, laga, nahi laga, ab laga. Hopefully it shouldn't be ab laga in this
Yeah.
case.
And then in the abdominal cavity. Fine.
Oh,
Oh, laga.
I have done the same
laga.
also.
No, everybody has
Everybody.
done. Everybody
There is nothing. As Dr. Samir Pradhan says, you have to be always be, very, very, very truth in whatever you're doing, in terms of life.
Yes.
He will ask you the same question. Such batao. That's what has happened now over here, right?
So again, how will you manage if a perforation you have created?
Yeah, who will take this? Who wants to take this case? Sandeep bhai? Yeah, please. Amol bhai.
Yeah. See, the diagnostic laparoscopy has been done. If there is a perforation is very small, nothing to worry about. You can just leave it. If it is
Yes.
actively bleeding, you have to take a 1 or 2 small sutures. Figure of 8 sutures can work. And
Sir,
firstly,
Amol
abandon
sir-
the procedure.
Amol sir,
Hysteroscopic
may I just
procedure has to
intervene?
be
When you
abandoned.
said that it's a very small one,
No,
how do you
this video
define
is
this
different
small?
and the previous video was a different video.
Oh,
The previous video was just you have gone into the false passage and you have perforated. This video
Without
is
an energy
different.
source. Amol sir,
Without energy source.
it
That
is
was
very, very
with the
important.
telescope.
But that really matters. Your
Yeah.
use of energy source versus use of a scissor or just with a scope really matters because all the three are different. When your management comes, it's all different.
Yes.
Yes, anybody else? Shambai?
The perforation, if it is caused with a simple dilator or with a hysteroscope, not using any energy source, then, and it's a small perforation with a dilator, then we can observe just in the, if there is no bleeding, or we can put a scope. If there is a simultaneous laparoscopy is going on, then we can see if there is a bleeding, then we can coagulate or take a suture there, or just there is no bleeding, we can observe in the ward, give the good antibiotic course, and then just an observation. But if it is by electrode or electrosurgical burn, then it should be bowel tracing should be there, check for the bladder injury, any vascular injuries there, and that should be deal with the same setting, or even laparotomy is needed, should be done in the same setting.
Shambai, if I may just intervene, in practical solutions, vascular injury with this is not very likely. Okay, bladder injury with this, unless until you are in the lower cervix and anteriorly, otherwise not much likely. Rishikesh, will you tell us your views on this, Rishikesh?
You can do the picture in picture with the one scope from above and one scope from the below. So that
पैसे नहीं है, पैसे नहीं, आपने कहा पैसे
इतना
नहीं
तो
है,
नहीं
एक
रहता।
स्कोप है, एक स्कोप है, ओ बोला।
We can see while
you can open the scissor vertical and then give transverse nick. Okay. If you just go on removing the transverse incision, I feel that you may directly.
Farendra bhai, can you just replay the video?
Trans elimination is there. There's some elimination in the we can see, or we can coordinate with the laparoscopy person where I'm at least there's a trans elimination from the hysteroscopy. Then we can just
or under ultrasound guidance also we can it can help, I think.
Yeah.
Especially Escherman, I prefer doing in ultrasound guidance.
Farendra bhai, can you please guide us over the ultrasound use and this Escherman, because I'm not very well versed with this.
Yes, in cases of grade 4 Escherman where there is no cavity, it is very difficult to find out whether you are going into the correct plane. See, yes, of course, water can guide you. Okay, I mean, here you are entering near to the serosa, so it can definitely better. The ultrasound is much better than your laparoscopy guidance. That is for sure. It can guide you that you are going into the wrong plane near the serosa, and that's not a correct plane. But going into the correct plane in case of grade 4 Escherman is very difficult with ultrasound. Again, I mean, I'm going to show you another case. In such cases, you all have to take the consent of, SOS laparoscopy, because if anybody of you is working in corporate, the charges straight away goes in a different level. See, you are doing a hysteroscopy, which might be costing around 35,000, and suddenly if you need to put a laparoscope, the charges will straight away goes to 1 lakh around. So how you are going to explain that beforehand to the patient? So the counseling and the SOS laparoscopy in all high-risk hysteroscopy cases should be counseled to the patient. And I might have to put a laparoscope as well. And pertaining to this false passage and high risk cases, as we have said, it comes with experience to go into the correct lane. You can use a last day of menses. If there's no menses, ultrasound guidance and expert surgeon to be needed in dealing with such cases. I'm going to show you the another case. This was a abandoned case. Grade 4 Asherman. Multiple times hysteroscopy was tried and people have gone into the false passage. And luckily, she has given us a last chance that, if we can try. So we have taken a laparoscopic guidance. We have assessed the fluid, assessed the tubes and ovary. And as you can see, the hysteroscopy view will show you there's no cervix at all. See, there's no portio vaginalis of cervix. So there was only a simple dimple, and you will have to negotiate through this dimple into a grade 4 Asherman, which is very high risk cases where you can perforate again.
Yes.
So in such cases, yes, we have taken a laparoscopic guidance. We were using ultrasound guidance. I am not able to record that ultrasound guidance, but here we are working in with our experience. Luckily, my team has a very senior hysteroscopic surgeon, so we get all such kind of referrals. So in this case, even we have perforated, as Dr. Anita was saying that she had done and then sutured it and then again tried, because this was a last chance. So it's the same thing we also did, but sometimes it's just a failure and you'll have to accept. Sometimes you may not be able to create any cavity. So this is all what I can say about this perforation things. And wherever there is...
Sometimes these postmenopausal ladies, when they have a small, very short uterine length, sir, there also the chances of perforating with just your scope itself when you go also is high, because the os, negotiating the os also is a little difficult in those
difficult thing.
A little more patience when we do postmenopausal uterus is important.
Parendra bhai, what I encountered is those patients with the previous LACS, who has many times people take a bikini incision, the cervix gets pulled up. And that time the diagnostic or anything, hysteroscopy is very difficult because the cervix is just pulled up. That time also we have to take care of all the things of the preparation, like mesoprost and all. It helps.
Yes, correct. Very nice. And this is the same thing which Rishikesh was talking, your scissor movement, it has to be transverse and vertical. So, these are very important things to negotiate and to enter an amount of pressure. But in spite of that, sometimes in very high risk cases, you can still do perforation. As we say, the first sign of perforation is sudden loss of visibility. This slide was given, Subhash was talking in one conference, and I said, yes, it's very important. Sudden loss of visibility, don't consider always as a perforation. Check your irrigation system. Check your inflow tubing. Suddenly there can be a kinking and you have lost the vision and you are suspecting there can be a perforation. And now, of course, you can suspect a perforation in the end.
And as put by Farender, think of common things first.
Yes.
Check for the tubings, check for the fluid, check for the cervix, then go inside, and perforation should be the last. Your index for suspicion of perforation should be high, but the chance of perforation are always less. Think of more common things like the fluid. Even the attachment of the fluid is gone. There is a kinking of the tube. The fluid is over. Think of these common things first. Secondly, I think I'll just take a detour because Anita, in the meantime, had spoken about ETCO2. Now, Anita, most of the cases when we do hysteroscopy, you're a slightly, on a joking note, a slightly posh surgeon. You go to big hospitals, you have ETCO2. Not many of us, Amol Bhai, and Shyam Bhai and many others will say that we also work in posh place, but kya hai ki paisa nahi parvarte, matlab it is not very feasible to use a ETCO2 for every case of GA, So what my point is again, if you have an ETCO2 and you attach an ETCO2, your ETCO2 goes down. That is your first sign of an embolism. Whereas your saturation of 92%, 90%, 80, 98%, which she said would give you more of a pulmonary edema. Now, that is the only case in when you have an ETCO2. If you have an ETCO2, attach it, because that will be the first thing that you would like to know about the embolism part of it. Now, coming down to the next part of it, now, I think as we have said, the practical, what we have done, what Dr. Farender has done, he's managed all the PowerPoints, the videos, and everything is Dr. Farender. I'm just the ghusa, matlab ghuspe to main. Okay. So the point is again now, is practical solution. I think we all need practical aspects. We are not much interested in theoretical aspect, but what are the practicalities? That's why we are more stressing on the practical aspects over here. I think the next point over here, Farinder bhai, the next thing is
Next is another important, I just wanted to show all of you this video. That's again an impending perforation. But if concentrate here, can you see my cursor? Suddenly you will see a movement of bowel here. That's a near perforation. With experience, you can really make out that you have very close to the serosal layer.
yes.
Yeah.
Yes.
Suddenly you can see. Again, I'll show you. That's a very
Amit bhai,
Yeah, we have
thanks
to
to
see
my
Amit bhai,
three
teacher,
times.
is he
Yeah.
there?
Dr.
Amit bhai,
Nahata.
Amit
he-
Tazane?
he has
Yes, I'm
given
here.
us a guidance. How can you
Okay,
deal
yes,
with such a
please.
difficult case?
One point I want to add it.
Yes, Amol bhai.
Yeah, when we are doing a hysteroscopy, always see the ultrasonographically UCL length, and
Yes.
when you are going inside, how much you are going you have gone inside. You must always aware of that. So the perforation happens when you go extremely inside, without knowing you have gone inside. So the ultrasonographically the UCL length is always you should keep in mind when you are doing any procedure.
Correct. So as you grow in the field of hysteroscopy, you suddenly realize that you need to do your own ultrasound. And it is extremely important when you are going into the complicated surgeries and you are excelling in the field of hysteroscopy. You should do your own ultrasound, assess everything, correlate with your clinical finding, correlate with your intra finding, and then teach and spread the knowledge of hysteroscopy everywhere. So this is what is our take-home message, and I think we thank Bhaskar Pal sir, all the organizers.
Before we end, may I invite Bhaskar Pal sir
Yes.
and if Sanjay Patel sir is there, may call Sanjay Patel sir also to give some tips, because we are not the right moderators, we are the middle level moderators. Let's call the experienced one.
Experts.